Top-Bed Talk.
I am a perioperative physician and a critical care physician in Southampton in the UK, and as such I lead a perioperative medicine service where we screen patients and measure their fitness prior to surgery, and we're engaged in exercise training. And in the next half an hour or so, I'm going to talk to you a little bit more about how we can go about screening and assessing fitness in the preoperative periods and what tools are available to us, particularly in the midst of what is a global pandemic. So why is this important? It's important because of this data, really. There is a very clear relationship between physical fitness and all-cause mortality. And this has been in all racial groups that have been investigated and in both sexes. And as you can see from this graph, in particular on the left-hand side, patients with low physical fitness on the x-axis have a much higher mortality. And very importantly, when we think of prehabilitation or exercise training, you get the greatest benefit in the most unfit patients in terms of mortality reductions. And there is this concept of a 15% reduction in mortality per metabolic equivalent increase in exercise capacity. And is physical inactivity or unfitness an increasing problem? Yes. We are in the midst, in fact, of another pandemic, that of physical inactivity worldwide, which is believed to cause more than 5 million deaths annually. And as you can see from the dark colours here, here we are in the UK with more than 40% of adults not reaching activity guidance. So fitness or functional capacity is really the summary of the effects of a patient's health behaviours, their comorbidities, and also psychological factors which affect motivation, such as mood, and also their belief in their ability to manage their healthcare condition. So the advantage of fitness in terms of predicting perioperative outcomes is that it incorporates all of these factors. And it is in itself, consequently, an important modifiable risk factor before major surgery, because we can modify health behaviours and exercise, and we can perhaps optimise comorbidities before surgery. So fitness in perioperative medicine is important because it allows us to evaluate the functional impact of a patient's comorbidities, and it also has utility in predicting both short-term and long-term perioperative harms. And finally, it's a modifiable risk factor. And if we are to go about modifying fitness before surgery, there are three processes essentially that we need to go through. First of all, we need to screen the patient, and then having screened them for problems with fitness or low physical activity, evaluate in more detail with a proper assessment, and finally, choose an intervention that's appropriate to that individual patient. Because as we heard from June, prehabilitation is about needs-based preoperative interventions based on evaluating a patient's particular requirements. So some patients may have mainly psychological problems, others fitness may be an issue, and in some patients fitness, nutrition and psychology may be a problem. So why do we need specific tools? Why can't we just ask the patient? Well, the problem is that the clinical assessment of fitness or functional capacity is in fact difficult. I think we can all identify the extremely fit and the extremely unfit, but the vast majority of our surgical patients fall into the ASA 2-3 category, where it can be difficult to evaluate the patient's fitness. When we think about assessing or evaluating fitness, we can think really of three different types of test. First of all, there's a subjective clinical assessment, as it were, the end of the bedogram, when you go to see the patient and sort of ask what sort of things they do. Next, there is subjective questionnaires, where we ask standardized questions of patients about physical activity and exercise behavior. And finally, there are some face-to-face objective tests that we can get the patient to do, such as cardiopulmonary exercise testing, or perhaps monitoring activity with an accelerometer. As we move along this series from left to right, they become more expensive, more complex, more time-consuming. And we want to direct our interventions to those at greatest need. So first, rather than evaluating all patients, we should screen them. So let's go through each of these in turn. First of all, let's talk about metabolic equivalence, or METs. It's a term that's bandied about a lot, and it's one of the ways that we subjectively evaluate exercise capacity. One MET is equivalent to resting oxygen consumption. So as I stand here in front of you, I'm using about 350 mils of oxygen consumption. And we can standardize all activity or exercise by measuring it in numbers of METs. And so they are used to estimate energy expenditure for many common physical activities. And here you can see a list of some activities and their metabolic equivalent, or their MET equivalent. I've divided them up into light and moderate and vigorous intensity activities. But I think you can all see quite quickly that there is a lot of greyness in terms of evaluating activities. So we have walking appearing under light, moderate and vigorous intensity, and what a brisk walk is may be interpreted differently by your patient than it is with you, which is one of the problems of this approach. The concept is that for each additional MET, the patient has a lower risk of perioperative events and of all-cause mortality in life. So how effective is subjective assessment of METs, or functional capacity or fitness, just by looking at the patient and asking them in a non-standardized way? Well, I think the best evaluation of this to date has been the MET study, which was published in The Lancet in 2018. And this was a prospective multi-center study where clinicians were blinded to objective measurement of exercise capacity and were asked to give a subjective assessment of patient exercise capacity. And in this study, as we'll come back to this study later, we looked at the Duke activity score, so an objective score of exercise capacity, measuring objectively with cardiopulmonary exercise testing, and also subjective assessment. And the one factor that was related to not a single post-operative patient outcome was the subjective clinical assessment of preoperative functional capacity or fitness. So for those of us who believe that we can assess patients' functional capacity accurately, or their fitness, I think this offers some caution in that approach. As we go on to look at more objective measures of exercise capacity, I think it's important to emphasize the difference between physical activity and exercise, both when we're assessing fitness and also later when we may be evaluating our exercise interventions. As you can see here, exercise is a subset of physical activity that involves repetitive, structured, planned movements. And it is quite clear that the biological effect of a high-intensity aerobic exercise program will not be the same as taking more steps in your daily activities of everyday life. It's not that either is not important. Both physical activity and exercise are important for maintaining good health. But in terms of interventions in the short period that is available before major surgery, it is exercise interventions rather than just changing physical activity that has been shown to have impact. So what sort of screening tools do we have? Let's first look at patient-completed questionnaires. There are numerous physical activity questionnaires, and I'm just going to cover a couple of these here to point out some of the problems and challenges for us as perioperative physicians. In terms of physical activity questionnaires, several of the most commonly used are, first of all, the International Physical Activity Questionnaire. There's a cancer-specific questionnaire, and also commonly in the UK now, general practice activity questionnaires, which aim to identify patients who should increase baseline physical activity. Let's first look at the International Physical Activity Questionnaire. You can see from the questions answered there, these really look at a balance of physical activity, as in how much walking you might do in a day, but also whether you do actually any regular exercise as well. The short form of this has 7 questions, and the longer form 31 questions, and you can triage patients into different levels of activity. The challenge for perioperative medicine with this questionnaire is that it has not been validated in a preoperative population, and we have no data on the relationship between IPAC, triaged physical activity, and surgical outcome. So not ideal currently, although it has been shown to be useful in other contexts. This cancer physical activity questionnaire, if you look at the detail of the questions, actually reasonably similar, and there is a lot of overlap in these physical activity questionnaires, and one of the major problems for us is there is not a gold standard for preoperative patients. Again, looking at how much strenuous activity the patient does in their leisure time rather than occupational time, how much moderate exercise, and any sort of physical activity, keeping active walking activity. From this, you can derive what's called a leisure score index, and there's a threshold value. If you are over 24 on the leisure index, which evaluates the number of METs of activity from the MET scores I showed you earlier on, and combines that with how long you spend doing each activity, gives you a single number, a continuous variable, and if that is above 24, you are said to meet activity guidelines and be active, and if it's 23 or below, you are insufficiently active. What that means in terms of the perioperative context, we don't know. So there is no data looking at this activity score and surgical outcome. The best validated index in the surgical population is probably the Duke Activity Status Index. Now, this was actually a fitness index which was originally derived to be used in heart failure patients as an approximation for METs or for VO2 peak. You can see there are a number of standardized questions which are answered yes or no, which are given a numeric value, and so you get an overall score. And there is also, as you can see at the bottom of the screen here, a means and a formula by which you can use this score to estimate a patient's VO2 peak. One of the issues with this score is that there is a floor effect, so the lowest VO2 peak you can measure is 10, and some of our patients do have a VO2 peak below this. And also, in terms of when the score was validated, the predictive precision of the Duke Activity Score was less good at predicting VO2 peak at low levels of physical activity, which after all is the group of patients that we particularly want to know about preoperatively. Having said that, DARSI has been prospectively evaluated, as I suggested earlier, in a large multi-center cohort study in the last few years, and that is the MET study that recruited individuals from Europe, the UK, North America and Canada, and also Australasia. As you can see, 1,400 patients had cardiopulmonary exercise testing, surgery and a DARSI score. But what you may also notice is that although this intended to be a high-risk population study, actually the majority of patients were ASA 2-3. They were a reasonably low median age group population, and importantly, for those of you familiar with peak oxygen uptake measures, these are actually relatively fit patients with an average VO2 peak, which is high for a general surgical population. So in that study, where we were looking at myocardial infarction and death within 30 days of surgery as the primary outcome, and death or myocardial injury within 30 days of surgery as secondary outcomes, the mortality rate was low. But in this context and in this population, we found that the DARSI score did associate with VO2 peak. You can see here on this graph, on the x-axis, we have VO2 peak estimated by the DARSI, and on the y-axis, the actual measured value of VO2 peak. So what's clearly evident here is there is a very large spread. So although on average a higher DARSI score is associated with a higher VO2 peak score, there is a lot of variability. So the patient may assess themselves as having a VO2 peak of 60, which is almost elite athlete standards, but when we measure them objectively, they have a VO2 peak of below 10, which would reach the threshold for requiring a heart transplant if you have cardiac failure. So again, showing the difficulty with subjective assessments of functional capacity. Despite that limitation, DASI was related to myocardial injury after cardiac surgery and the primary outcome. So we do know that the DASI score does relate to postoperative complications, and it does approximate to fitness. And so in surgical patients, it probably represents the best validated fitness scoring system that a patient can fill out that we have to date. A subsequent secondary analysis of the METS data, which included patients who didn't have a cardiopulmonary exercise test but did have a DASI score, as well as the other core subset of patients, also looked in greater detail at the relationship between DASI and outcome, and found that with a cutoff of 34, and that's not in terms of VO2 peak, but the absolute number from the score, the patients below 34 had a higher risk of both postoperative MI and moderate to severe complications. And again, it's worth pointing out that if you looked at the patients whose DASI score was less than 34 on this objective test and saw which had been identified as high risk by clinicians, only 15% of those patients were identified by a subjective clinical evaluation. Finally, it's important to say that perhaps the absolute numerical number in the DASI questionnaire is better than the estimate of VO2 peak at evaluating physical activity, in that we found the equivalent in the MET study of a DASI score of 34 was only 17 mils per kilo, or 5 METs, whereas if you use the predictive equation, that would have been 7 METs. So the conversion formula may not be that valid. So looking to the future, what about patient wearables, wearable technology, activity monitors? Is there any evidence that we can use these? Well, this may well become very much a growth area, and we have seen an explosion of small studies in the last few years. But to date, there is in fact no extensive data validating their use in clinical patients in the preoperative population, either to evaluate fitness or indeed to evaluate fitness exercise interventions, although there are several ongoing trials currently. You can see this was a meta-analysis looking at physical activity and postoperative length of hospital stay, and there are some studies looking at that, and that's where patients wear monitors in hospital. But to date, there's only been one study that's looked at preoperative accelerometry with a patient wearable and its relationship to postoperative outcome and also to response to a training intervention. And this was in a very small, so pilot study only at this date, but encouraging looking data with 35 elderly patients who were deemed high risk with a clinical frailty scale of more than 4 for postoperative complications, who attended a preoperative clinic, were given a activity monitor, an accelerometer, and this was worn for 7 days. They then had a behavioral change exercise intervention and again wore the accelerometer for a week after the intervention. And as you can see, on average, there was an increase in accelerometry taken steps after the physical activity intervention. Very interestingly, however, the accelerometry data was also looked at in comparison to a physical activity validated questionnaire in the elderly, and there was no relation between the two. So really, overall, we're not sure which is the important or the better measure of fitness or activity in terms of predicting postoperative outcome. And we urgently need some large multi-center cohort studies to address this question. So I've reviewed the fitness screening tools. What about fitness assessments? And I've divided these up into face-to-face. First of all, simple field tests, and then the gold standard for fitness assessment, which is a cardiopulmonary exercise test. So the simple field tests have been proposed as something really in between just asking some questions of a patient and the full cardiopulmonary exercise test that we will refer to later, which is reasonably complex and requires trained individuals. The field tests I'm going to tell you about, there's 3, and there is essentially reasonably sparse data to date in terms of their validation, again, in a surgical population. So, again, a requirement for some multi-center prospective studies looking at different methods for evaluating fitness and relating those to surgical outcome. The first and perhaps the most simple is the timed up and go test. This measures the time it takes for a patient to stand from sitting in a chair, walk 3 meters, turn around, walk 3 meters back, and sit down again. So clearly, ideally directed at frailer, more elderly patients and commonly used as part of the frailty assessment in the Edmonton Frailty Scale. But it has been evaluated in a single multi-center surgical cohort where the relationship between the time get up and go score with a score of more than 20 seconds identifying a high-risk group, and showed that actually it was reasonably accurate in identifying a high-risk group with a much higher incidence of complications, of prolonged hospital stay, and multidisciplinary involvement in the postoperative period. So some interesting early data in a high-risk population, unclear whether there may be a ceiling effect, however, in fit patients who are likely to have very low timed up and go scores. Next, we have the 6-minute walk test. This is a self-paced test whereby a patient walks as far as they can on a hard, flat surface over 6 minutes. There is a significant learning effect, so ideally this needs to be repeated twice. So on the whole, not actually a terribly short or very simple intervention, and it's very important in order to be objective to keep standardized instructions. Because it's self-paced, it's actually a measure of submaximal exercise capacity rather than maximal exercise capacity. And as you can see from this data here, again, from the same population of patients in the MET study, where the 6-minute walk test was evaluated against cardiopulmonary exercise testing, really only a very weak relationship between the 6-minute walk distance and VO2 peak. And again, looking at outcome post-operatively at a year, there's clearly a floor effect where most patients did not had good disability-free survival and very poor relationship between the 6-minute walk test and disability-free survival at 1 year. Furthermore, in this study, the 6-minute walk test did not associate well with the incidence of significant major postoperative complications. So, although you can identify a low fitness cohort with this test, in particular those who can walk less than 430 meters, perhaps not ideal in terms of the accuracy of identifying a high-risk population. The incremental shuttle walk test is another fitness test, but in this time it's externally paced, and as such the patient tries to walk incrementally faster along a 10-meter walk, 10-meter course, and they stop when they can no longer continue, and the pace is set by the investigator and they have to walk faster and faster. As a maximal exercise test, it associates better with VO2 peak measures in the limited data that is available, and in fact a distance of less than 350 meters on this test does identify a higher risk group with a VO2 peak of under 15 mils per kilo who may be at higher risk of post-op complications. So finally, moving on to cardiopulmonary exercise testing. This is generally regarded as the gold standard for measuring aerobic fitness because it's an objective test which has been demonstrated to be highly reproducible, and on top of it being reproducible, it also allows us to interrogate the exercise response in detail and so evaluate what the cause of exercise limitation is if exercise capacity is impaired. And we can derive from this test a number of indices of cardiorespiratory fitness. The test is well tolerated by patients. It is actually only 7 to 8 minutes of high-intensity exercise, and exercising on a bicycle, which is done in the majority of preoperative tests, is actually reasonably easy even for very frail and elderly patients, and patients over the age of 80 have been assessed using this test. There are a number of indices of cardiorespiratory fitness derived from the test, which are continuous variables. These are the VO2 peak, the anaerobic threshold, which look at peak exercise and sustainable exercise capacity, and then VCO2, gives an index of VQ matching and gas exchange efficiency, which has been shown to be important in predicting long-term outcome after surgery and cancer treatments, and heart failure also. Cardiopulmonary exercise testing can also be used to measure endurance time, which is a submaximal exercise test, which is particularly sensitive to fitness interventions. So if you are to exercise train a patient, you want to know whether your exercise intervention has been effective, i.e. has the patient changed their fitness, because we know that some patients don't comply with exercise training programs. So before we suggest that an exercise training program doesn't work, we actually need to know if the patient did the exercise. And so it's important to have a sensitive test of exercise interventions, and endurance time is very sensitive from that aspect. Does exercise capacity as measured by cardiopulmonary exercise testing predict surgical outcome? Well, this was a classical paper produced by Paul Older back in the 90s, where he demonstrated that anaerobic threshold was associated with postoperative mortality, and he subsequently intervened to triage patients based on their anaerobic threshold, either to perioperative elective critical care or not, and reduced inpatient postoperative mortality. Subsequent to that initial paper from Australia, there have been a number of cohort studies over the ensuing 20 years, looking at many different patient subsets. I would say the weakness of this literature is that it is often single center, and in some cases clinicians were not blinded to the cardiopulmonary exercise testing results when outcome was assessed. So there may be some confounding by indication, but overall it is clear that there is an association between objectively measured fitness and surgical outcome, both morbidity and mortality. The predictive precision in any given procedure is something that requires greater clarification, particularly with contemporaneous surgical cohorts, since surgery and types of technique have changed, and we now have had the advent of, in particular, laparoscopic surgery. So cardiopulmonary exercise testing measured fitness variables do associate with postoperative outcomes, and we have seen that in all major intracavity surgery, thoracic and abdominal, that has been evaluated. And also we know more recently from exercise training intervention studies, and this is from a prospective study looking at colorectal cancer patients during, both before and after chemoradiotherapy, before colorectal cancer surgery. And we demonstrated in this study, and this is from Sandy Jack and my colleagues in Southampton, that during chemoradiotherapy, objectively measured fitness decreases in terms of both VO2 peak and anaerobic threshold, and that if you exercise train patients after chemoradiotherapy, you can improve their fitness, and that this corresponds to improvements in quality of life. So again, in terms of cardiopulmonary exercise testing data, there is a suggestion that it is sensitive to exercise interventions, and that these may be translated to improved postoperative outcomes. But the downside of this intervention is that it is more complex and expensive. So really, we should be perhaps thinking about using this intervention for those groups that we have screened at potentially being at higher risk of a poor outcome, and these may be the groups that we need to focus our prehabilitation interventions upon, particularly the specialist interventions. So moving on to COVID-19 and current challenges for fitness evaluation. I think first of all it's very important to bear in mind what the risks are for patients attending hospital. So any fitness evaluation that involves face-to-face contact, so that would include all the simple objective exercise tests I've covered, and also clearly cardiopulmonary exercise testing, there's a risk to the patient coming to a hospital environment, particularly if they have comorbidities that render them the group that are at high risk of a poor outcome with COVID should they be exposed to it in hospital. Then also there's a risk to the exercise testing staff from the patient should they perhaps be infected without knowing it with COVID. And as I said, this affects all face-to-face patient testing. So I have a second role as president of the Perioperative Exercise Testing and Training Society, and this is a society that evaluates and trains and provides guidance for perioperative exercise testing and exercise interventions. And we've reviewed all the literature surrounding exercise testing and the evidence for its causing aerosol generation of viral particles. And there is now a statement which you can get from the Perioperative Exercise Testing and Training Society website, but I've summarized here on this slide. And it essentially says now, as elective surgery restarts, certainly in the UK after the surge phase of the COVID pandemic, we still face a risk to our patients. And so when considering exercise testing, it needs to be weighed up on an individual patient basis. The risks to that patient of attending hospital versus the benefits to be had in terms of their perioperative preparation and perhaps the use of your exercise test to direct preoperative interventions aimed at improving that patient's outcome. The patient needs to be aware of the risk of attending hospital, and if at all possible, then the preoperative visits for a CPET test should be combined with other essential visits in the preoperative period. In terms of screening, the patient should ideally have a negative COVID test prior to attending for a CPET in hospital, and on the day of attendance, all patients should be screened for symptoms of COVID-19 and for a fever, and clearly testing should not take place for a positive patient. In terms of the test itself, there is little data objectively to be sure about this. It is widely accepted that cardiopulmonary exercise testing, as lung function testing is, represents probably an aerosol generating procedure. And as we should be cautious in protecting staff in this eventuality, it means that when testing patients during the COVID pandemic, we should wear PPE in keeping with that recommended by your local either infection control or your national guidance. In the UK, that's Public Health England, for a aerosol generating procedure, which in the UK would be an FP3 mask, a visor, gloves, and a gown. Having completed the test, we also have to take into account the removal of the generated particles from the room, and so ventilation and extending the time between patients is important, and you need to involve your local infection control team to offer some advice about the time necessary to be left between patients. So, in summary, as part of the preoperative workup process that is core to perioperative medicine, screening patients early in the pathway is key. In terms of physical activity screening, the best validated questionnaire is currently the Duke Activity Status Index, although it has some weaknesses for identifying low fitness individuals. Patients identified as of low fitness should then perhaps go on to have a more detailed evaluation, which may take the form of cardiopulmonary exercise testing, which may be used to identify poorly optimized comorbidities and also to identify targets to be used during exercise interventions for those that require specialist interventions preoperatively. These should be evaluated in parallel with nutritional and psychological needs, ideally in a multimodal prehab program. I think it's really important that we remember that physical inactivity is a major health burden and an increasing burden in our surgical population. And currently, whilst the waiting times in many countries have been extended for cancer surgery because of the COVID pandemic, it is really important that we focus on patients who are waiting for surgery doing something useful during that wait. And exercise training is something that could be extremely beneficial for this patient cohort. You will hear later in the conference from Sandy Jack, one of my colleagues in Southampton, who is leading a multi-center national study, SafeFit, looking at exercise and nutritional and psychological support in cancer patients before major surgery with a distant, non-face-to-face intervention by physical exercise training professionals. And I think I'll leave you with this thought. We should perhaps focus more on physical activity and less on therapeutic interventions sometimes when we think about patients being optimized for their subsequent surgery. Many thanks for listening.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.